My point of view on this is that despite the fact that we know, like we really know now in 2023, how EMR should be performed. And what do I mean? I mean that there is an evidence base for a particular way to do this procedure. And we have deconstructed it, and it's all out there, it's all published. But despite that, there is variation in practice, significant variation in practice. We know that because there is people out there who we observe who are performing polypectomy not to the standard which is outlined in this document. We see rates of post-colonoscopy colorectal cancer which are unacceptably high, and some of that is related to incomplete polypectomy. And we see patients going for surgery because of incomplete polypectomy, where the patient comes back later either with a recurrence of a polyp or a cancer at the place of the polypectomy.
Now, the modern way to train a technical skill is to have what we call competency-based training. So we teach people the components of the technique, let's call them competencies. And a curriculum really outlines all the knowledge and technical skills that people need to have. So it's like a checklist, a framework on which to hang your training. And it really helps you make sure that you don't miss anything out.
In terms of marking the snare, that is something we put in the polypectomy curriculum as well. There were two alternative views. You said to me, you can't articulate a feeling. I definitely think I can articulate a feeling, and I articulate it by using the word spongy. So I think all my trainees who I teach this way, and a lot of them are here, so let's ask them, of course, no pressure guys, might understand that that thing that you take the snare and then you feel the tissue, and you can very much immediately feel whether it's hard, indicating entrapped muscularis propria, or whether it is spongy, indicating entrapped submucosa, plus or hopefully not just mucosa. I mean, Lobke, first, maybe you comment on that, because you are also trained in the Michael Burke School of EMR, and then maybe get the others to say whether they think it's useful or not.
Yeah, so this case is about a referred patient who was referred for a large lesion, presumably at the valve of 40 millimeters, granular, as you see in the picture. There is 2A1S with a prominent nodule. When we saw it, it was actually a bit distal to the valve. Yeah, this is a patient, quite important, in his 60s, no major comorbidities. So we decided to do piecemeal EMR. We calculated the risk of SMRC to be low.
If you're, in control of it, what are you seeing from yourself here, which makes you think actually maybe?
I hate to say it, but what I feel here is that I'm thinking, well, it will probably be all right, and it will probably be in a good injection, and that is something that you, if you can, want to avoid, and that is something I would tell myself, I think 2 years ago. Don't be happy with the probably.
Yeah, don't be happy with second best or third best or anything other than first best. Okay, so you would tell the you of 2 years ago to turn it. So I think you do that, don't you?